Her interest in metabolism, nutrition, and prevention of metabolic diseases started in college as a Division I tennis player and led her to pursue a career in medicine and specialization in endocrinology. She graduated from the University of Connecticut School of Medicine with a merit scholarship. She then completed her residency in internal medicine at Duke University, um, and fellowship training in endocrinology at Hopkins, before she came to New York to join Mount Sinai. She's been published in many different journals and avenues, including the New York Times, U.S. U.S. World and News Reports, New York Magazine, The Cut, and on CBS News Sunday Morning, and in on-town newspapers as well. She's dedicated to care of patients with obesity, diabetes, and metabolic diseases, and building research in obesity here at Mount Sinai. So if you can please join me in welcoming Dr. Srinath.
Good morning. Just want to make sure everyone can hear me okay. So thank you so much for that kind invitation, and very excited to be here. Very, growing time in this sort of field. So in terms of, I'll jump just right in, disclosures. I did have research funding from Dexcom for an investigator-initiated study completed last year looking at the use of Dexcom CGM in overweight and obesity, which we're presenting an abstract next month at Obesity Week, and manuscripts in preparation. In terms of today's objectives, a bit of a whirlwind. One, to review the trajectory of obesity medicine and how we've really transitioned towards complication-centric care. Two, talking about current and pipeline medications. And three, the focus of today is really thinking about small pearls and how we can help these patients, and using very small vignettes to address some of the topics I've written out here. So as many of you know, the pandemic is growing. The CDC and their BRFSS maps are shown here, and I know that these are probably advancing by the day. By 2030, it's predicted at least 1 billion people living with obesity with a BMI over 30. That would be 1 in 5 men and 1 in 7 women. We know that the spending is growing and that there are more than 200 health conditions linked to weight, which is really why my interest and my focus is really we need to prioritize weight. We need to prioritize this from the start to help these patients and reduce the risk of complications of this disease. Why is weight gain so easy? Well, we know there are many factors. It starts with genetics. We know there's our physiology. Psychological factors, our behavior, the environment we live in, such exposure to high caloric foods. Add to that hormonal changes over the lifespan and metabolic factors. So numerous factors here that incorporate and can impact our weight over time. And so while the first drug for weight loss was probably started in the 60s, the field of medicine really didn't start formalizing till the 90s, much, much later. We have in 1998, the National Heart, Lung, and Blood Institute put out their first guidelines, which really identified and started really introducing the idea of screening patients for weight and obesity. As you can see over time, we've had the American Heart Association, Obesity Society in 2013, the Endocrine Society produced their guidelines. And in the last year, I'll highlight in 2025, I was really proud to be on the steering committee to develop the ACE algorithm for the evaluation for treatment of adults with obesity and ABCD. In the last few months, the European Association for the Study of Obesity put out their framework, and the Canadian Obesity Society has also put out their framework. So numerous guidelines all published in the last 3 months. So what we're shifting towards is thinking about weight as a number. It is not just a number, it is not just their body mass index. In 2023, the summer of 2023, the American Medical Association put out a policy recognizing the harms of BMI, understanding that there are historical harm, this idea that these numbers were developed from populations decades ago, non-Hispanic white populations, and it may not match our current environment, a patient's gender, their ethnicity. This year, the Lancet Commission underwent a thorough guideline and task force to identify what is the definition of obesity. And they created 2 categories. And their commission said there is preclinical obesity, which is defined by having excess adiposity without end organ damage or end organ manifestations. And there is clinical obesity, which is defined by having presence of excess adiposity with alterations and clinical manifestations. And our guidelines have shifted to address this specific definition. So we're moving towards using a comprehensive model for care, starting with our history examination, gathering data, their weight, body mass index, waist circumference if we can, our physical exam, and then we look at physical staging. So those patients who have at least one mild to moderate complication, that could be hypertension, diabetes, sleep apnea, or severe complications are considered to have higher stage. And those patients who have higher stage are then triaged towards more aggressive therapy. And our tenets of care include lifestyle modification, behavioral therapy, anti-obesity, pharmacotherapy, and bariatric surgery for those patients. So again, more aggressive care for those patients who have more aggressive complications and manifestations of this disease. The question then rises, what is considered meaningful weight loss? What I tell patients is there is not a number I'm trying to get you to. There is not a specific number for you, but there is the journey. I want to see if they can lose, ideally 5%. We know that they will help multiple metabolic parameters, their liver, their diabetes risk, sleep apnea, knee arthritis. But ideally, I would like patients to lose at least 10 or more than 15%. So when patients lose at least 10 to 15% of their body weight, no matter where they came from, we know that there is significant improvement in metabolic parameters, type 2 diabetes, treatment remission, cardiovascular risk, metabolic dysfunction-associated steatosis, sleep apnea, knee arthritis. So again, magic number, 10 to 15%. I've listed here the weight loss drugs we have in the market right now. We've got our single agents. We've got our dual agents, starting with orlistat, phentermine, both developed in the 60s. Excuse me, orlistat was in the 90s. Qsymia, Contrave came about in 2012, 2014. And then we have our incretin therapies. So I can also subdivide this into considering first generation medications and second generation medications, where second generation are these injectables: liraglutide, Saxenda, semaglutide, known as Wegovy, and tirzepatide, known as Zepbound. And keep in mind, these are the versions that are FDA approved for weight loss. So many of the studies, as I explained earlier, have tried to create their own framework. The idea is to create a hierarchy as to how we can individualize care. The understanding is that these hierarchies are based on clinical trial data. Many of these clinical trials are ongoing, so we don't know yet. But I can say if someone has type 2 diabetes, you really want them on a tirzepatide or semaglutide product. And we've addressed several alternatives if they can't get those medications. If someone has knee osteoarthritis, ideally, I'd really want them to get semaglutide based on clinical data showing improvement in physical parameters and outcomes. Similarly, with sleep apnea, obstructive sleep apnea, at least moderate to severe, we have tremendous data now with tirzepatide showing clinical benefit. So again, thinking about how we can individualize care and prioritize based on complications of weight. But it's important to know that it's not a one-fit-all approach. Not everyone needs an injection. So this is a study in 2021 from the Mayo Clinic. And what they did is they assessed 450 participants and they divided them. Hungry brain were given phentermine topiramate extended release. Hungry gut were given liraglutide 3 milligrams. Slow burn were given phentermine with resistance training. And those with emotional hunger were given naltrexone bupropion sustained release. And these assessments were based on surveys, questionnaires, metabolic testing, assessments of blood work, as well as genetic testing. But what they found was that over 12 months, those who were treated based on their phenotype lost more weight, approximately 15.9% weight loss at 12 months, compared to 9% for those who were not phenotyped. So again, the idea is that we really need to individualize care and figure out, why is this person gaining weight? It may not just be that they're overeating. They may have a slow metabolism. They may just be stress eating. There are reasons, and there can be ways that we can address that. And I want to hint at the pipeline, because while we have a growing number of injections, like Wegovy, tirzepatide, or Zepbound, we now have new oral formulations. So semaglutide at 25 milligrams is going to go for FDA approval, hopefully next spring. Orforglipron from Eli Lilly, which is a non-peptide GLP-1 agonist, which allows flexibility in timing of dose, likely also in 2026 FDA approval. We have our GLP-GIP agonists like tirzepatide. We have a single GIP agonist. And the category I'm sort of excited by is amylin. We've been using amylin in the setting of type 1 diabetes to help patients with insulin sensitivity and improve satiety. And we have a long-acting form of amylin called cagrilintide, which is once weekly. They have combined cagrilintide with Wegovy, semaglutide, at 2.4 milligrams once weekly. Studies have shown that there is weight loss up to 20% or more at 1 year. That's almost equivalent to Eli Lilly's Zepbound. So very exciting data coming out. We also have, not to forget, our triple G, retatrutide, which is our GLP, GIP, and glucagon agonist, with data showing weight loss up to 25% or more. So we are growing in our sort of percentage weight loss, which is clearly approaching bariatric surgery as well. What I'm next going to jump to is talking about some clinical cases and how we can help patients in the clinical setting. So this is a classic 56-year-old patient coming to me. He has hypertension, obstructive sleep apnea, at least moderate, and he is coming for follow-up, and he was started on tirzepatide 3 months ago. You can see his baseline weight here, 244 pounds with a BMI of 41. At this visit, he is 216 pounds. His BMI is 38. He has lost 11.4% weight in 3 months. You look at his diet, that does not look good. A muffin in the morning, a solid dinner. He's having a protein, he's having a fiber, he's having a starch. He otherwise has no complaints, but his wife is worried. Why is he losing this much weight so fast? 3 months is really short. The question is, what is the next step? Do we, A, assess nutritional labs, really concerned about this rapid weight loss? Do we counsel him on healthy eating? Do we refer nutrition to really get him to eat better? Or do we say, this is way too fast, you need to lower your dose of Zepbound? So how do we approach these patients? Really, we want to start with the 5A approach. This was developed for motivational interviewing. Ask, assess, advise, agree, and assist. What we know is that we need to get a full 24-hour dietary intake. We need to know what they're eating, the time, how late before dinner and bedtime, how frequently they're eating out or doing delivery, and fluid intake. That makes a big difference. We want to assess their clinical symptoms. This particular patient feels great. A lot of my patients tell me I'm having dizziness, I'm feeling weak, I'm feeling nauseous. Those are concerning red flags that you should be aware of. We want to focus on quality. We know that their appetite is less. They really have to focus on the quality of food over quantity. And they have to understand with any medication, as they go up in their dose, their intake is going to change. Their food aversions might change as well. So it's a growing conversation. These are some basic labs that we want to address to look for nutrient deficiencies. As many of you know, a complete blood count, a comprehensive metabolic panel. I do assess nutrition labs, so checking our vitamin levels, B12, folate, iron, ferritin, as well as our bone health. Our markers for bone health, magnesium, phosphorus, 25-hydroxyvitamin D, and then looking at prealbumin and albumin. So in patients like this, I'm definitely doing a full panel of blood work within 6 to 12 months of them starting on any weight loss therapy. And this was a really elegant paper that came out last year from Jamie Almondos from UT Southwestern. I've put sort of the key points here. So for patients who are on weight loss agents, they should be taking in at least 1 to 1.5 grams per kilogram per day of protein. That is the first. But we have to parallel that with fiber. We are not talking enough about fiber. We need to be getting at least 20 grams in women and at least 30 grams in men. In terms of carbohydrates, I'm not a fan of the super low carb. We need to be getting at least 45 to 65% of the daily energy intake as carbohydrates, 20 to 35% as fat, and they really need to up their fluid intake, so at least 2 to 3 liters. So that was sort of a summary quickly of nutrition. So next I'm going to jump to symptoms. So this is a phone call I got a few weeks ago. 29-year-old come to you, sends a message through the MyChart. I've been throwing up for the last 24 hours. What should I do? She took her second dose of tirzepatide, Zepbound 5 milligrams, Thursday. This message is Monday morning. Her symptoms started Saturday, and she's been really sick. She's not dizzy anymore. She's been resting. She's now taking in fluids, but she doesn't know what to do because her next dose is Thursday. That's coming up in 4 days. And she wonders, should I lower my dose? Is this too much? Am I not a candidate for Zepbound? Should I switch to something else? Or do we just need more information? Is this a patient where I need to get a sort of a sense of, what did she eat the 24 hours before the injection? Maybe she went out, and one of my patients yesterday said, I had fried chicken at 9 o'clock and I took my Zepbound at 10 o'clock. I was really sick that night. And we had to provide counseling that that was probably not the best thing to eat right before your injection. Then the question is, does she just wait it out and give her next dose that Thursday? So this is actually harder to see, but what we know is from Surmount 1 and STEP 1, the two first clinical trials with semaglutide and tirzepatide, that at least a quarter, up to 44% of patients experience some GI side effects. Keep in mind, this was mild to moderate in nature. It sort of subsided over time, and it did exacerbate every time they dose escalated. So every time they went from a dose, the symptoms got worse. Then they got better. None of it really led to discontinuation of therapy. So we have to be aware that this is the most common side effect. And so for patients who come to you with concern about these side effects, it's really important to counsel them. Yes, it's going to happen when you escalate your dose. It's going to happen if you go on vacation and skip your medication for 2 weeks, and then you resume your medicine right afterward. And what I do counsel patients are some of these key tenets. One, eating slowly, thinking about portions, thinking about no straw, which actually helps with gas and fluids. And then looking at the food composition, we talk about fat, so low fat, we talk about fiber, and a lot of fluids. For patients who are really worried, one, as I talked about, you really want to get a sense of what they're eating. And also, could this just be a stomach bug? Could they have eaten something wrong and they're developing some food poisoning or GI virus? So it could be that versus a side effect of the medication. We want to make sure they're eating well. We want to provide symptom-focused care. So some patients might need a Zofran. They might need something for gas. They might need something for their bowel movements. And yes, in this situation, if this patient was still having active nausea, she wasn't eating well, I would delay that dose for Thursday. And I would tell her, delay it by a few days till you're clinically better. And yes, we're going to stay on this dose for at least another month, maybe another month after that, until your tolerability improves. So really important to understand that we cannot escalate until tolerability is good and they are able to tolerate the medicine. And if this continues, every time I up their dose or for every dose she takes over the next few weeks, that's definitely a situation where I might switch her to an alternate medication. So jumping now to a big topic, weight maintenance. So this is a woman, 49 years old, coming to me for follow-up on phentermine topiramate extended release. You can see her weight here, 190 pounds with a BMI of 34. 18 months later, her weight is 150 pounds. She has a BMI of 28. She has lost 18% of her weight over the last 18 months, which is not uncommon. I've seen a lot of great results on Qsymia. She follows a Mediterranean diet. She's eating really well. She's active. She's walking. She's moving. She's doing yoga a few days a week. So she's engaged in strengthening and toning. And then she's questioning, do I continue on this medicine? So our options here are, one, do we start her to de-escalate her therapy and tell her, yeah, you've done great. You can get off this medicine. B, do we discuss lowering her dose to the lowest dose tolerated where she can maintain her weight? C, do we just continue for forever? Or D, do we say, hey, you've done great, but maybe you want to consider a stronger drug and maybe lose more weight and consider a transition to tirzepatide? So why is weight maintenance so hard? The biggest factor here is this idea of metabolic adaptation. As we lose weight, at least a quarter of that mass is lean muscle mass. When we lose lean muscle, our metabolic rate is slowing. So then we are not burning the calories the way we used to. Our intake is lowering. So we are creating sort of a new set point, a new normal, as I tell patients. Every time we lose further weight, we are creating a new steady state, a new normal. Add to that, as you lose weight, our gut hormones are activated. So we've got ghrelin rising, telling you to eat, telling you to feel hungry. We've got GLP-1 levels rising, which are telling you to eat less. And we have other hormones, cholecystokinin, peptide YY, leptin, insulin, which are all impacting your appetite, your fat deposition. Add to that other factors, our genetics, our psychological factors, and then hormonal changes. I see a lot of patients who come to me with on therapy, doing great, going through menopause, perimenopause, or pregnancy, postpartum, where there is weight gain that occurs with hormonal changes over the lifespan. So keeping that in mind. And this is why weight maintenance is so hard. There are two really elegant trials here, STEP 4 and Surmount 4. So both of these withdrew the drug. So in STEP 4, at 20 weeks, patients on semaglutide were randomized to placebo or continued on therapy. And as you can see, those who were randomized to placebo regained 6.9% of their weight. Those who continued on therapy lost another 7.9% of their body weight, which I think is quite unique and unique to this trial. If you look at the similar study with Zepbound at 36 weeks, patients were randomized to placebo. You can see they've regained significantly up to 10% of the weight they've lost. And those who continued to lose with an average weight loss of 25%. This shows us that these are long-term medications. When they discontinue drug, there is risk of regain. So we have to counsel patients that these are chronic long-term agents, which is why these drug companies have developed maintenance doses. So if you start a patient on Wegovy, you're starting them at the starter dose of 0.25. Every month you're going up, but you want to get them to the 1.7 or the 2.4, which are considered maintenance doses. What I will say is that Novo Nordisk, there is a little bit of pressure with Wegovy to get to these max doses because of the insurance coverage. They sometimes will not cover the lower doses if you continue them for a long period of time. Compare that with tirzepatide, where if you start at 5, they designate 5, 10, and 15 milligrams as maintenance. So for patients who are on these drugs, particularly with Zepbound, if they really tell you, I want to use the lowest dose possible and maintain as well as I can, you may want to try to get them Zepbound because it allows much more flexibility in dosing because of these lower doses, which are considered maintenance doses based on insurance as well. And I forgot to mention, we don't have maintenance or sort of dosing with Qsymia aware of right now. The big sort of study, which this is older from 2008, but I think it drives home the point. We know dietary changes sort of support weight loss in our journey. However, exercise is what helps keep it off. So this was a study in over 200 participants where they were all on a caloric restricted diet, randomized to various amounts of exercise. So in the diamonds, we have less than 150 minutes. In the square in the orange, we have 150 to 249 and 250 to 299. And in the triangles, we have those who are doing over 300 minutes of exercise. Patients were followed over 24 weeks, and you can see those in the triangles who were exercising at least 300 minutes per week, or those who were able to maintain the most of their initial weight loss. So again, driving home the point that we need to be moving. So as I talked about earlier, this metabolic adaptation, we know that up to a quarter or more of the mass loss is being lean muscle. We need to have patients engaging and taking at least 1 to 1.5 grams per kilogram of protein per day. We need to make sure they're engaging at least 2 days of strengthening and toning. And when I tell patients it could be yoga, could be Pilates, could be squats, I actually started writing patients a little prescription, 10 squats, 10 lunges, 10 push-ups, 10 ankle raises every day. And I've started writing it for every single patient. As patients approach that maintenance phase, yes, you can de-escalate. You can lower their dose if they really want you to, but you also have to warn them they might regain a little bit. And we're learning more. This is actually a study done from my colleagues at Eli Lilly. So they're actually going to look at weight maintenance. So they're going to study patients randomized to tirzepatide. They're going to get them to a place where they feel comfortable. They're at a stable weight, and then they're going to lower that dose. And they're going to see how patients do at the lower doses and who can maintain the best. So this is a study that's currently recruiting, and hopefully we'll have data in the next few years. What I'm next going to jump to is how do we address patients who don't have coverage? So this is a 66-year-old who has new prediabetes. She is coming to you with concerns. She has hypertension, obstructive sleep apnea. She is engaged in lifestyle intervention. She is seeing nutrition. She is walking at least 10,000 steps per day. But these labs are really worrisome. Her A1C is now 6.2%. Her blood sugar is 112 fasting. And she knows these injections exist. She's interested, but she also was told Medicare doesn't cover them. So the question is, what do we do next? And I've listed some options here. Do we start her on metformin, knowing the data with prediabetes and weight loss? Do we put her through an oral glucose tolerance test to really assess her diabetes risk? Do we obtain records of her sleep her sleep study to assess maybe she can be considered for Zepbound, which is approved for moderate to severe sleep apnea? Or do we put her on Qsymia, phentermine, topiramate, extended release, and say, here, you've got controlled hypertension. This drug is approved. Even if you cannot pay for it, it's about $95. It's not that bad in terms of cost. So this is what I famously refer to as the dig. Patient comes to you and is interested in injectable therapy. This is where we are going to start gathering as much data as possible. I'm looking through their charts, looking for every fasting blood sugar, every A1C that exists in EPIC. Yes, in this patient, I'm going to put her through an oral glucose tolerance test to identify, does she have risk of diabetes? If that blood sugar fasting is above 125 or her 2-hour glucose is above 200, that would qualify her for an injectable, for diabetes, excuse me. And yes, I'm going to tell her, you need to find that original sleep study. If there was moderate to severe sleep study present, if there was moderate to severe obstructive sleep apnea present, she would qualify for Zepbound, and that is including Medicare. And last but not least, if she has active heart disease or presence of an elevated coronary calcium score, she could qualify for Wegovy, which has been FDA approved since March of 2024 for obesity and cardiovascular disease. So yes, I'm going to put these patients through all of this to see if they can get a medication if they really want it. I put this slide up. Many of my fellows know that I love metformin. It is an oldie. We know it was approved in the 90s, but this is a study in 2021 out of Cornell. So they used over 200 patients, and they looked at metformin use in patients without diabetes. So they had in blue patients with euglycemia, and in red patients with type 2 or pre-diabetes. And what I point out here is this category. So at 12 months, almost 20, like 30 or more percent lost more than 10% of their body weight who didn't have diabetes. Those who had pre or type 2 diabetes, also a large percentage of them lost more than 10% of their body weight. So I do use a lot of metformin in patients who don't qualify or may not have access to weight loss medications, because we do know that with lifestyle interventions, they can do well. They can lose potentially up to 10%, which is one of our initial goals. Another alternative to cover is phentermine topiramate. So this was the original study from 2012 or prior to approval, but weight loss over 108 weeks was approximately 10 to 11%. That's not too bad. And a lot of patients have done really well. I mentioned the dosing here. So you start, and the starting dose has 3.75 milligrams of phentermine, 23 milligrams of topiramate. As you go up, your max dose is 15 and 92 milligrams of topiramate. Through the Qsymia Engage program, you can get this medication self-pay for about $98 per month. So if you go to the website, the patient signs up, they can get it shipped to them directly for $98. And I think that is, for some, reasonable. Not to forget, naltrexone bupropion extended release, approved in 2014. So Contrave has also been approved for binge eating disorder. In terms of dosing, when you get to max, you're taking 2 pills in the morning and 2 pills at night. That's equivalent to about 32 milligrams total of naltrexone and about close to 400 milligrams of bupropion. So in patients who have specific mood disorders or depression, anxiety, have been on these medications before, who express disordered eating behaviors, portion control issues, this might be a good option. I also mentioned their savings program. So if you go to contrave.com, you can also get their patient savings for self-pay, paying about $99 per month, where the drug is shipped to you directly. So another option. And for those patients who really are wanting an injection, who don't have coverage and want to pay for it out of pocket, Eli Lilly has come up with these self-dose vials. So each vial is a single dose. The starter dose of 2.5 milligrams is $349 per month. The follow-up doses are $499 per month. Keep in mind, they are tracking how you fill this medicine. They don't want you stocking up on supply. So if you don't fill this within 45 days, that cost goes up to almost $550. So we have to make sure patients are following and refilling it properly. And as of July 1st, Novo Nordisk also, in competition, created their self-pay option. So you can now get Wegovy or Ozempic for $4.99 per month at any commercial pharmacy. I understand that Costco put up an ad saying that you can get Ozempic for $4.99. That is available at any pharmacy. And if a patient is worried that it's not concurring at their pharmacy, you can send them to NovoCare, which is a mail order, and they'll ship it to them directly for $4.99 per month. I'm next going to jump to transitions. So this is a very similar 66-year-old who is also concerned about her diabetes risk. She is doing the same interventions. Her A1C is 6.2. Her blood sugar fasting is 112, but her weight is 250 pounds. She has a BMI of 41.6 kilograms per meter squared. And the question is, where do we go here? Do we put her on metformin? Given all this data I've told you, she can lose at least 10% of their body weight. Is that significant? Is that enough? Do we put her on semaglutide 0.25? And do we use a diagnosis of type 2 diabetes? Can I even get this covered? Probably not. Do I put her on Qsymia and tell her to pay out of pocket? Or do I refer her to bariatric surgery? So we have data now growing about the effectiveness of bariatric surgery, specifically in type 2 diabetes. This is actually a pooled analysis of 4 randomized controlled trials. 305 participants were randomized to medical lifestyle management or bariatric surgery. You can see their average age of 49.9 years, BMI of 36.4, and they all had uncontrolled type 2 diabetes. A1C average was 8.4. One limitation here, it was open label. They know what they were doing. But what I can show you is that, yes, there was greater effectiveness for diabetes remission. What I want to show you here, though, is as you look at these curves, the greatest percentage of remission was in that first 2 years. Over time, with bariatric surgery, those numbers do come down. Compare that to with medical therapy, those numbers are going up, but it's sort of still not the same as having bariatric surgery. In a similar study published this year out of colleagues from Cleveland Clinic, they also looked at complications and followed patients for over 10 years. And these were identified from 2010 to 2017. They had a BMI of 41 with type 2 diabetes and obesity. And in terms of key outcomes here, so over this duration of follow-up, there was 32% lower risk of death. There was 35% lower risk for MACE, and the mean weight loss over time was 21.6% in those undergoing bariatric surgery compared to negative 6.8 in those who are on medications. So keeping in mind more significant weight loss over time. The one limitation I would say of this study was that it was only through late 2022. Keep in mind, Wegovy just got approved in late 2021 and Zepbound just got approved in 2024. So their use of weight loss medications were limited to Trulicity, Byetta, and Ozempic and other medications. But again, showing potential benefit in certain situations in patients with BMI over 40 where metabolic surgery is more effective. There have also been now studies looking at cost effectiveness. So in this study out of JAMA Surgery 2025, just last month, they looked at comparing bariatric surgery to patients on GLP-1. The mean cost here for GLP-1, over $63,000 versus, and this is over 2 years, those who were on getting metabolic surgery, the average cost was around $51,794. So there was significant difference. But if you look at the trajectories, the majority of the cost with bariatric surgery was in that first 6 to 12 months, getting through the surgery, dealing with complications of the surgery. For those who were on medications, that increase in cost was really over the 2 years, and they continued to accumulate and pay for medication. So I want to keep that in mind. So in the situation, you have a patient with a BMI over 40 or over 35 with these comorbidities, heart disease, type 2 diabetes, or obstructive sleep apnea. You have to start the discussion. And I do start it. I want to speak broadly. We have to tell them, if medications don't work, we ought to consider bariatric surgery. So in someone who has maybe a contraindication, that might be someone, they have history of pancreatitis, or they have history of maybe medullary thyroid cancer. That's someone definitely who would be a candidate here. Someone who is a non-responder, they've tried weight loss medications, they've lost less than 10% of their body weight. That's someone who may consider, or you may want to talk about considering bariatric surgery. Someone who doesn't have any coverage for weight loss meds and have these criteria is someone else who you want to consider. And then we do have a population of patients who come to us saying, hey, I need to have a transplant, I need to have a knee surgery, a hip surgery. They want me to lose at least 30% or some specific number for weight in order to get through this surgery. And so those who really need to lose a lot of weight, I start them on medication, but if things aren't passing and process, and if they're not progressing well, I then do talk about bariatric surgery. So really depending on the threshold weight loss they need to go through this surgical procedure, that's someone you may want to consider. So in summary, again, a huge whirlwind of what I've spoken about, but I really want to emphasize how we're trying to move towards individualizing care, how we're looking at not just the initial data, but clinical staging and mirroring the development of these medications, the use of medications to tailor care based on how aggressive their disease is and what degree of complications is present. And I share this interesting, I found this interesting, just this idea of this overlap between weight, adiposity, and cardiorenal liver metabolic disease. So we know at stage 1, we have weight gain. At stage 2, we might have what we call preclinical disease. We have these risk factors: impaired glucose tolerance, potential risk of fatty liver disease, mild CKD. As you get to stage 3, we have worsening type 2 diabetes, advanced fibrosis on liver imaging, as well as potentially diastolic heart failure, a moderate CKD. And then stage 4 is an advanced disease. So again, the idea that obesity is tightly linked to all these metabolic complications. So if we can capture these patients up here or up here where they have preclinical disease, that would be the most effective approach to prevent developing more severe complications. With that, I'm going to summarize. So what we've spoken about today is that weight in what we call adiposity-based chronic disease is a complex multifactorial disease with multiple complications. We want to really incorporate staging into our assessment, and we want to parallel severity of disease with our management. We know that outcomes should include weight loss, but really we want to look at what are the improvements in their blood pressure, their cholesterol, their diabetes parameters, their heart disease, and looking at that in addition to the weight itself. And last but not least, we have a growing number of drugs in pipeline, which I think is really, really exciting. We know there's growing access issues, and we're still learning about these drugs, but I think the next 5 to 10 years will be really, really exciting and fun to see. With that, I will say thank you. I just want to thank some of the people who have supported and mentored me: our current division chief, Andrea Denave, Carol Levy, and our Diabetes Center, Jeff Mechanic, our former division chief, Yaron Tomer. I'll mention a sort of side note. When I first came to Mount Sinai, he and I had a long conversation. I mentioned my interest in weight management. He sent me to Boston University to work with Carolina Povian, who was at that point one of the internationally renowned obesity specialists. For 2 weeks, I was able to shadow and work with her and bring that here in 2015. So I'm very indebted to him. Adrian Dobbs, who was my mentor in fellowship, and all of our faculty. And these are my boys running through the High Line looking for ice cream. So with that, I will say thank you.
Thank you very much for the wonderful talk. We now have some time for questions. So, yes, Dr. Dunn?
Yeah, thanks for the great talk.
Sure.
You mentioned selecting the agent based to some degree on the comorbidities like sleep apnea.
Yeah.
Do you think that's more a function of the study that was published versus an effect of the agent itself? In other words, would equal weight loss lead to certain benefits and certain comorbidities, or is it more?
Yeah, I think that's a good question. I think they're doing further analyses of the SURMOUNT sleep apnea study to identify, and they did have arms looking at patients who were treated with CPAP versus not. So I think there's definitely needs to be more research on that, because I agree with this weight loss, and I see this, patients who are not getting treated, they lose the weight, their sleep apnea is getting better. So I agree completely. Yeah.
Advanced endoscopy.
Yep. Yeah. Yeah. Yeah, so we talked about the role of GI and advanced endoscopy and looking at what we call endoscopic sleeve gastroplasty and some of the what we call dual balloon or saline balloon studies. So we are now doing more endoscopic sleeve gastroplasty. Weight loss has been shown up to 10 to 15% at 6 to 12 months, which is a huge thing. I have a few patients who have gone through this. The limiting factor right now is insurance coverage, and cost out of pocket is at least $10,000 to $15,000 self-pay. So I think once that is FDA approved, it's FDA approved. Once that is covered by more and more insurances, I do think that endoscopic sleeve gastroplasty could be a growing sort of intervention device that could be used in parallel in many of these frameworks. In terms of duodenal mucosal resurfacing, I actually was the PI on our study with Fractal, looking at duodenal mucosal resurfacing in type 2 diabetes. We had 3 subjects go through and do really well. I think there needs to be more data in terms of durability, side effects, and how this, again, fits into our armamentarium of options.
Can I ask a question?
Great talk. 2 questions I'll allow. First is, the most frequent question I get asked from patients is long-term plan here. So
the study showed that if you just taking medications, then weight loss goes up. Weight loss goes down, or weight gain goes up. What are your thoughts there? And what do you think is the whole thing medications in the long-term maintenance?
Yeah.
And then second is, what are your thoughts about referral to a specialty clinic like yours versus treatment within primary care or other subspecialty companies?
Yeah. So the question was about sort of use long term. So I think that patients do really well on many injectables, but yes, we have to counsel them. This is long term. What I generally tell patients is expect to be on this for a few years. God knows what's going to come out, and we know there are now oral agents. So in the future, yes, I do foresee some patients who achieve their goal weight who may want to switch to an oral option and just maintain at a low dose. I think that the expectation is when they stop, and I've seen this. I had a patient now, one patient who's been on injectable since 2015. There are cycles, weight gain, weight loss, weight gain, weight loss. So over time, unfortunately, our body is adapting. So metabolic adaptation sort of still can trump a lot of this, but I think it's really important to counsel them that lifestyle matters, the physical activity matters, the protein intake, all of those parameters. If they're engaging in those, that's going to help them to have the most success. Regards to your second question, in terms of where and how we should do or sort of engage in obesity medicine, I think that while yes, I would love to have all the referrals, I'm only one person. Our division is very small, but and we're growing. But I think that this can be done in primary care, and I think it's really important that we start doing this in the other subspecialties and doing this in the proper way and having patients followed. And yes, if there needs to be more help, they can be referred. But I think jump-starting the process, getting them on therapy, getting them in a lifestyle plan is really key.
Thank you so much for your great talk. Two questions from the Zoom chat. One is, how did you find out about the 4 types of obesity and how that informed the different types of management that corresponded to each phenotype? And then second was, do you use a FIB-4 calculation in informing any of your clinical decisions?
So the question was a study from Acosta and Mayo Clinic looking at how we characterize. Let me see if I can find it here. But yes, so how did they do this? They looked at surveys of satiety, food intake. They looked at dietary intake. They looked at metabolic testing. They looked at metabolic parameters, muscle, fat mass, and of course, now I'm not going to find it. Those were the key things that they did. I have to blank if they did any genetic testing. But using that data, as you saw, they did create these categories, and patients did really well. So yeah, I think it's really important to assess patients because we have a lot of patients who, yes, here we go. So yeah, so if you look at it, percentages, a lot of them had sort of the overeating, hungry gut, large portions, eating late at night, snacking. They were the ones who got the GLP-1s. People who were sort of emotionally eating, they're like, I'm stressed, I'm eating, I need to eat, I'm studying. These are the ones who actually do really well with Contrave, naltrexone, bupropion. And then we have a large population. I have a lot of patients, women in particular, postmenopause, men over 50, 60, where their metabolism is just slowed. They've lost a lot of muscle mass. And those are patients where I really emphasize the lifestyle interventions, the strengthening, the toning, the movement. And yes, in certain situations, I'm using a lot of phentermine or phentermine topiramate. So, yeah. There was a second question. Yes, so FIB-4. So in terms of utilizing the FIB-4, yes, I think we need to do this more and more in terms of this overlap with fat, obesity, and with liver disease. We know that Wegovy is now, as of September, approved for metabolic dysfunction associated steatosis. There has to be presence of F2 or F3 fibrosis. So I'm doing more and more of a FIB-4 scores for my patients. You do need your liver enzymes, you do need your platelet count, you need their age as well as other parameters. And those patients who have an elevated score should get a FibroScan, more specific evaluation to get screened and appropriately treated. Right,
Well,
thank you.
if there are no further questions, thank you again for this wonderful talk.